All right, everybody can see it. Hello? Can you see it?
Yes, yes,
All
yes.
right. All right, so to start our discussion, again, thank you for the invite, Dr. Halasa. And recently, the rise of IV drip bars and IV hydration stations are seen usually for the purpose of the hangover treatments, dehydration from the flu, or even overexertion. Food poisoning, jet lags, getting an instant healthy glow for skin and hair. These are even endorsed by celebrities such as Kim Kardashian, Simon Cowell, even Rihanna. So let's dig deeper on what is the secret with these IV drips that everyone wants to get into. It's a very broad focus, as you can see, but mostly I want to focus on the most common one, which is a multivitamin mineral therapy drip. They may name it the jet lag drip, beauty and skin, immune booster, anti-fatigue, and yes, I also have heard of the knockout punch, waker up, or the big uppercut. They sound like wrestler names, but the concept is that they are just all multivitamin mineral drips with various mixtures and dosing that defines their effects. Here are my credentials before I start. Just want to thank again Dr. Halasa and CDPM for this invitation. My mentors, Dr. Cora, Dr. Forsyth, Dr. Majid, Dr. Clearfield, my bio staff, especially Lucy and Minnie here, my left and right arm in the clinic. What would I do without you guys? Our bio-integrative staff, the patients whom we serve every day, our audience for your time, and most important of all, the one above who gave us the healing hand to treat. Well, when I started, I don't know where to specialize in this field of integrative medicine. Would it be supplements, acupuncture, energy medicine? I saw that our IV station here gives the most, I guess, impactful effects on my patients, which is very fast. And of course, as the one that caught my attention is 100% delivery of anything that you give through these IV therapies. Great risks, great rewards, but also the slightest dosing error can cause harm. Well, how I started, I needed to know how it feels. So I ended up trying all my IVs and all the IMs here in the clinic on myself, being my own guinea pig. This is how I look like after from this very professional look that I have here. But my point here, really, why I show you this picture is how I am very extremely passionate about IV therapies and IM therapies. And hopefully you guys can get the message as well as I deliver this presentation to you. So our presentation is not only applying to practitioners that does IV therapies, but also the ones who can do intramuscular therapies. So where did it all start? It all started with the Myers cocktail. It was developed by Dr. John Myers, not John Mayer, the singer. He's a physician in Maryland in the 1970s. Dr. Myers used the cocktail to treat his patients with a variety of conditions, including fatigue, migraines, and fibromyalgia. The cocktail is a form of IV micronutrient therapy. The term Myers cocktail didn't come into being until after, unfortunately, the death of Dr. Myers in 1984. Presently, the evolution have paved way for other mixtures and dosing leading to our present IV selections. It only has 4 ingredients, which is actually vitamin B, vitamin C, magnesium, and calcium. So that's how basic it was during that time. So you can see anybody can actually start their own basic IV therapy concoctions. Even as a rookie or a newbie, you can start with this and it's very safe. Components of the multivitamin mineral drip. One is vitamin or vitamins. These are organic compounds. We only need a small amount for our bodies to actually run with the metabolic reactions that we require. There are 2 sources for this. One would be internal, which is actually some synthesized by the body, but not enough for bodily needs. Example of this would be tryptophan, of course, turning into niacin. And also there is an external source for this, which is actually what we get from food, injectables, and even what Stefan's doing are supplements, our oral supplements. And here, the next one would be what we call the minerals. The minerals are what we consider as essential elements for, again, multiple bodily functions. Common ones would be potassium, magnesium, chromium, calcium. In the IV world, we are going to talk more about the positive ions, mostly salts. salt form, which is actually example, a more prominent example would be potassium chloride. Here's a sample multivitamin mineral infusion concoction. Most common that we use, you will see this in many drip bars, but it varies for different practitioners. Notice here the methylfolate is something that I actually, or folinic acid that I highlighted here, and not folic acid, due to the MTHFR gene deletion prominence in our population. Always remember that almost 50% of the population has this specific deletion. So this kind of differs us from the ones who are really aware of the concepts of IV therapy versus the one who's just doing it like as a one-stop shop or who doesn't even research about these things. And here are the sample minerals that we commonly use in these infusions: magnesium, zinc, chromium, selenium, calcium, and potassium. Well, we will discuss more about the water-soluble vitamins, which are commonly used in the IV world. This one is hard to overdose on due to the quick renal excretion involved in their metabolism. Even side effects are rarely seen. Most of them would be nausea if given in a fast drip or higher dosing. The ADEK or ADEK fat-soluble ones are rarely given in a multivitamin bag, but it is still possible as an infusion. But you don't see that usually in the commercial world. So watch out for those patients who plays around with their roller. It started above when you started the IV, then now it's below in front of their face. You know who I'm talking about? People who want to get out and do it quick. So be cautious about these customers or patients of yours. And we all know nutritional or natural-based studies are just a few, but majority of the literature that I will be presenting today will be in IV form, but some also will mention about oral as well. So B1 is thiamine. It's actually used in carbohydrate metabolism for energy production, involved in oxidative decarboxylation, which is actually a carboxylate group that is being removed to form CO2. Out of all the Bs, this is the one that your patient can probably be sensitive to. And again, when I say sensitivity, it's not really going into anaphylactic shock. It's mostly like, yes, a skin rash or even just itching. But if you really have a high suspicion, you can do a skin test on this one. And available in 100 milligram per mil, you can do it IM or IV form, usually declared as safe even in higher doses. It was not associated with any overdosing at all in any of the studies done on this. So when we think of thiamine, we always think about this will be in situations of extreme alcohol intake, not the minor ones, like the moderate alcohol intake. It's more of the extremes that are the ones who are probably deficient in B1. This is related to the complication called Wernicke-Korsakoff syndrome, which is the encephalopathy with impaired, of course, gait, memory, and vision caused by excessive alcohol intake. And also, we also have this tendency now to lose thiamine or B1 for our current grains and beans are getting processed and being refined. And in this whole process, B1 gets depleted. Though commonly seen in third world countries, but also still present in ours because of the high processing that we also get with our current food source. And a condition related to the deficiency of B1 would be beriberi, wherein when we define wet beriberi, it's classified under cardiac, and when you say dry beriberi, it's more of neurologic. That is why it is not harmful to try B1 on any of your CHF patients or even neuropathy patients to see if it might be helpful with their symptoms. As I mentioned to you, the food that we have now is almost comparable to third world countries because of the processing. So it can happen with our fast food, with our processed meats. So definitely worth a try. It is also found to be beneficial for Parkinson's disease. In this study, 50 patients were given 100 milligrams of thiamine IM 2 times a week without any change to personal therapy, meaning most of them were actually taking their levodopa, carbidopa. So the protocol, again, for us, I also use this in my Parkinson's patients to be effective in reversing Parkinson's disease motor and non-motor symptoms. This results may be seen in a month to 3 months. And that's actually similar to what the study had done, making B1 deficiency possibly related to the development of Parkinson's disease. B2, so let's talk about now the components of a B complex as we dissect them as we move forward. This is usually not found as an individual, but in a B complex solution. Useful in conditions such as chronic microcytic hyperchromic anemia, where it enhances absorption of iron and zinc. Important in the formation of the most potent type of B6, which is 5p5 or pyridoxal 5-phosphate. And you would also see here that the promotion of the production of FAD or flavin adenine dinucleotide, which, as you see here, the different functions of. And usually we hear more about when we want to lower homocysteine, the methylated B12s, and also methylated folates in the methionine cycle. But B2 is also important in the formation of 5-MTHF as well. And I'll show you that in this specific graph. So here you would see the methionine cycle, wherein B2 plays a big role in converting 5,10-MTHF to 5-MTHF, leading to the involvement of lowering down our nemesis for cardiovascular disease called homocysteine. The common antioxidants that we know of usually are named vitamin A, C, and E. But vitamin B2 is a non-popular antioxidant. May it be dependent on its own, or dependent on other factors, or independent on its own. It recycles glutathione to the reduced form to neutralize hydrogen peroxide, and by itself alone can be an antioxidant. So you will see here how glutathione reductase uses FAD or FAD, which is coming from B2, to convert oxidized glutathione to reduce glutathione. I wanted to show you a per Oren study on how to address a common ailment with B2. With migraines, usually triptans and NSAIDs are the go-tos, which leads to the side effects of course, conventional medicine. Here, just B2 alone, a 400 milligram per day for 2 to 4 months, led to a significant effect. You can see that supplements are slower but effective and can be used with conventional therapy as you wean them off even from it. B3, again, rare as an individual, usually as part of the B complex concoction, and niacin converts to B3. Consider it low in patients who has hyperlipidemia and cardiovascular disease, so it's worth replacing it for these situations. B3 must not, again, don't be mixing this with niacin, for it does not produce flushing like its counterpart, niacin. Thus, we don't have to be afraid of that. It also increases NAD, leading to mitochondrial genesis and increased muscle performance. So don't only think about nicotinamide riboside or NR or nicotinamide mononucleotide NMN to increase NAD. B3 has this ability as well. The famous use of B3 is in dermatology, and here's a study of the benefits via topical and even the aesthetic benefits of B3. So we already know the power of NAD. Here, mitochondrial myopathy patients have NAD deficiency in muscle and also in blood. Niacin is an effective NAD booster in humans, and also niacin improves muscle strength and fatty liver in mitochondrial myopathy. Niacin also boosts muscle mitochondrial biogenesis and also the respiratory chain activity in humans. Dexpanthenol, or B5, it is also in 250 milligrams per mil form, and pantothenic acid is the alcohol form of this, involved in the carbohydrate and fat metabolism, also used in stress hormone support. Clinically, I use this also with my BHRT patients and also cortisol challenged patients, doing this at least 1 time a week as a supportive therapy. And here are the doses and how I use them. Very benign, very safe. And again, the big hook here for patients would be the hormone therapy that they're on. Here's an interesting study since I see a lot of allergic rhinitis recently. This shows how effective B5 is as a nasal spray for congestion. So maybe this is for the Mike to concoct and add to his nasal decongestants. So B6, which is pyridoxine, available in 100 milligrams per mil, needed for carbohydrate, protein, fat metabolism, considered to be low in malignancy, drug therapy, malabsorption, and also alcohol intake. And so consider adding this to these specific conditions that I just mentioned. This should be given diluted, or it can cause dizziness or phlebitis if given as a straight IV push. This can interact with levodopa, carbidopa if given more than 5 milligrams per day, where it promotes the effects of dopamine decarboxylase, which is actually neutralized by carbidopa or levodopa. So caution when your patient's actually taking this specific medicine. Figure 1 here, you would see that, again, we use to lower homocysteine, always thinking about methylfolic acid or methyl B12. But here you would see how B6 contributes to lowering down homocysteine by converting it to cysteine. Always remember, you correlate pyridoxine with nausea. PO is safe or oral safe in pregnancy, especially in hyperemesis gravidarum. I have done IV in pregnancy in the first trimester, but I do not recommend this. This is only for extreme cases. It's not because it's not safe in pregnancy, but if something happens to the pregnancy, you don't want to be blamed for that. That's why if you want to give it, you really need to explain it to the patient or definitely get your consents done. It is also useful with the famous GLP-1 agonist associated nausea. I think Dr. Bill has used this in his formula as well. The B complex is actually, I just ran them through, is composed of thiamine, riboflavin, dexpanthenol, and pyridoxine. And I use B complex in IM form, 1 ml commonly for energy boosting, hormone support. Usually I add B12 to that. And if you want to go IV, you can actually use 2 mils. Usually rare in terms of adverse reactions or effects, but mostly nausea if rapidly infused in your IV form. So let me take this chance to thank our favorite lab rats as subjects for providing data that we have now for drugs that we use in humans. Do you ever think they have a clue? They believe in conspiracy theories as well, as I see. B-complex studies were originally done on rats, setting the stage for current human clinical benefits. We all know that neuropathic pain is hard to treat, like trigeminal neuralgia and post-shingles pain. As the head-to-head study was done, it compared B-complex plus B12 versus B12 alone versus carbamazepine, drug of choice for neuropathy such as this. And the one that won the study is actually the B complex plus B12. And this was given 5 days straight. The key here in the study and also in clinical practice is the administration of the medicine, especially as how fresh the injury is and also how proximate you are from the day of injury. As we all know, nerves are pretty hard to regenerate. That's why timing is of the essence. Study also shows here that the combination of Bs is more beneficial for diabetic neuropathies rather than individual therapies. Again, combination of Bs are synergistic and more cost effective and even more effective. And when I say B complex, you always want to put B12 in that concoction. So B12, the cobalamins, they may be most famous for all the Bs, out of all the Bs out there. And let's break them down. Cyanocobalamin is the most common given IM and also the most studied, though there is what we call the news about it producing cyanide. And again, cyanide production is noted at 20 micrograms per dose, and poisoning symptoms are non-specific, such as headaches, weakness, generalized weakness, which can lead to seizures and even thyroid problems. But again, this is something that the body can dispose of. I'm not advocating for it, but it's just that it's the one that has the most literature of out of all the B12s. But usually this is detoxified by the liver. Thus, if it's going to be given to a specific patient, you have to make sure that you check the liver enzymes and they have to be of normal liver functions. The next one would be hydroxycobalamin. It is a long-acting form. It binds to proteins longer than cyanocobalamin, and it's best given IM or IV. And the other one is methylcobalamin. It's the most active form, usually best used for neuropathies in IM. It converts homocysteine to methionine. It also regenerates myelin sheaths. And common doses would be 1,000 micrograms. Increased dosing can still be safe, and there are rare overdoses since it's also, again, kidney excreted. Still, we need to caution about overmethylation, which is a whole nother topic. If a reaction does occur with B12, it's usually the preservative. And of course, do you know that we all know, I guess, tinnitus is very hard to treat. B12 is definitely worth trying, for it can be considered even first line since it's cheap and also very accessible. But do not forget to rule out other main causes for tinnitus, such as acoustic neuroma, exposures to loud noises, aspirin use, overdose or overuse of aspirin. Um, so large doses are okay, as you can see in this trial. And in this trial, the subjects who benefited from B12 actually were found to be B12 deficient, thus being the cause of their tinnitus. So we already know, us clinicians, we know this. We already know the power of IV versus IM, but there are your patients who justifies and saying to you that oral is fine, oral is the same as IV. It's going in, going out, getting absorbed, right? But I'll just take oral. That's usually how they end up. But most of them are just trying to save money. But this study says otherwise, and we all know this. This is not something that we encounter in our current setups or outpatient setups, but I just wanted to bring it to your attention how powerful high dose IV B12 is in relation to improving patients in septic shock. So these are actually ICU patients who went through this specific trial. Folic acid. It's available in 5 to 30 milligrams per mil, and preferably folinic or even methylfolate, which is the more absorbable version, but short half-life and expensive. Though caution, for it can clog filters when you use folic acid due to its reaction with other ingredients in your IV bag. Usually it's magnesium, that's the suspect. That's why you need to have filters if you're going to be playing around with folic acid. I use, at least for my IM, 0.5 to 1 milligram per day, and use it on patients with megaloblastic anemia, which is known to be with low folate or high MCHC or high MCV. For IV, 5 to 20 milligrams. And again, mix this last in your bag because it's actually something that will clog again. And I use a separate drawing syringe for this. It has a very low overdose profile since studies had shown 400 milligrams per day for 5 months or even 10 milligrams for 5 years showed safety. Watch out in the future or just be cautious about using this. High doses of folic acid accelerated progression of cancer. Folate used in DNA synthesis and cell proliferation. The basis for this, again, you would remember the medication called methotrexate, which is an antifolate used in chemotherapy. These are small studies, but even though it has a low overdose profile, we need to be cautious in using this. In this diagram, you will see folate and B12 again converting homocysteine to methionine. So this is the part where we kind of know the true stars of the homocysteine therapy, which is B12 and folate, methylated. And here you would see that 5-MTHF shows that it can actually increase nitric oxide in our system. So everybody's into nitric oxide nowadays. And as you can see, why 5-MTHF or even, we have methylated Bs in our famous nitric oxide booster brands. So the most popular of the antioxidants, which is actually ascorbic acid or vitamin C, is actually helping to produce collagen when it is added to lysyl and prolyl hydroxylase. Deficiency doesn't occur anymore. It usually happens in several countries again, and also from the fortification of food, thus prevents deficiencies in our situation. And when we have deficiencies, we always have the problems of scurvy and then also poor wound healing. I would not suggest this to be given as an IV push or an IM due to the high osmolality, thus causing a lot of pain. If the pain, again, during infusion occurs, buffer your solution with sodium bicarbonate 8.4%, not calcium. I will show you later why when we have the calcium discussion. And for the most common doses would be, of course, the 500 milligrams per mil in a multivitamin mineral bag. It's usually less than 50 grams. And when you go over 50 grams, that's when you now have the pro-oxidative effects. So the less than 50 antioxidant, more than 50 grams pro-oxidative. It is also a mild chelator. Thus, we have to make sure replace calcium by 10 grams of when you give vitamin C in 10 grams, equating to at least 1 ml of calcium gluconate. So calcium won't. I don't want you to go that high in terms of the replacement here. So for a 50-gram vitamin C, use at least 200 milligrams calcium chloride or even 1 ml of calcium gluconate. We also know this phenomena of blood sugar spikes when we're using vitamin C. Again, this is due to it being a hexose derivative, meaning a monosaccharide containing 6 carbon atoms. So it shows up as glucose in your glucometer. So more than 15 grams, the peroxide that it produces actually goes intracellularly. And that's why this is actually used in cancer and chronic viral infections. 25 to 75 grams, watch out for possible dehydration because now it can act as osmotic diuresis. And also it can lower now your blood sugar significantly. And whenever somebody's going to do a vitamin C drip, always make sure they hydrate and also with electrolytes, and also make sure they eat during or even before the infusion occurs. One thing that I actually use this for in our cancer practice would be positive PET scan findings when they're actually getting evaluated. So as we all know, in pets, we use FDG, fluorodeoxyglucose. So the concept here is the cancer cells, of course, consumes carbohydrates or sugars. So the dye in your PET scan is actually the FDG, and it gets absorbed. So when actually we have patients who are PET positive for METs, these are the ones that are actually found to be best responders to high dose vitamin C due to the high GLUT4 activity, which is the transporter for the vitamin C and even sugar to go into the cell. So basically, yes, metastatic disease will benefit from vitamin C, even without the PET scan. Though we always thought testosterone is the most common one responsible for increased libido, 3,000 milligrams per day for 14 days led to increased penile and vaginal intercourse and also lower down depression scores. This is a PO study, but worth mentioning. So guess who's throwing away the Viagra tonight? This guy. He is on target and he knows what time it is. So minerals. So our favorite magnesium, usually used 500 milligrams per mil. The sulfate form is used for mostly asthma, cramps, migraines. And when I use this, I make sure if I do this as a push, it's diluted 3 mils maximum. 6 mils, if you go higher than that, is now should be done in a drip form or IV form. The reason for that is there's a risk of hypotension. This should be observed again as you go higher in the dosing of your magnesium. The reason why we have an access for a drip, so just in case hypotension does occur, you now have a line to, again, replete your patient. So learn from my error. One of our patients received magnesium as a push by mistake. In terms of the higher dose, this ended her being on the floor with increased heart rates and palpitations. She thought she was going to die. Fortunately, she was okay after that. But again, we have an IV access for this patient. That's why we repleted her. So most of us, you have to remember, we have low magnesium due to the current food processing that our nutrition goes through nowadays. And also, this is the reason why it should be part of all IV therapies that we do for our patients. And also known for its antihypertensive effects and even calming properties. You will see here how magnesium acts like a calcium channel blocker, which actually lowers down the risk of cardiovascular stimulation, thus lowering blood pressure and even heart rate. So it sits on the calcium receptor channel to block calcium for its, I guess, possible stimulation. And then here you would also see that in magnesium, it actually is a remedy for one of the more common problems that we encounter in our practices. These are the migraines that we see every day, especially for our hormone patients. And most of the time we approach this in the hormone world through addressing progesterone, because we know low progesterone does produce or aggravates migraine conditions. And acute treatments for migraines using magnesium actually, the dose here is 1,000 milligrams IV with or without aura found to be effective. We are usually worried about the cardio and renal toxicity of magnesium. In this study, 4 grams in 100 mil was given. Okay, I do not recommend this, but I just showed you this study to show how it's safe. But this is something that you should probably not do. And you have to remember, these were under controlled conditions when they did this study. I know that, again, this study infused this solution in a 4-hour duration in a very slow drip. We are worried about the cardio and renal effects, but now studies have shown that it's actually safe. So don't do this. I just want to show you that magnesium is something really, I guess we shouldn't be worried about it if used the right way. Calcium, 10% calcium gluconate is the one available in the market, which is 100 milligrams per mil. As I always suggest, stick with the lowest range of suggested dosing and no intramusculars for this one, because this will lead into necroses or abscesses. If you want to avoid a lawsuit, you're definitely not going to do that. So not mixed with lipid emulsions as well, such as phosphatidylcholine, alpha lipoic acid, which will form non-visible precipitates. You should store this in room temperature only. Only even after opening it again, you should probably, I have seen practices do this and put it in the fridge, and you would notice that there will be, again, visible precipitates that will form. And in terms of adverse reactions, if given too much, well, it'll just shut down your cardiovascular system. So we don't want that. Giving IV, you should note for, again, muscular contractions during the infusion, which is actually normal, and mostly described as patients like feeling crampy during the IV. So we just have to guide our patient that this is a normal reactions while you're receiving calcium. Being in a cancer center, this is significant for me. We all know platinum drugs are related to peripheral neuropathies post-treatment. So pre and post oxaliplatin infusion, giving 1 gram of magnesium and also calcium, so of each, can be a neuroprotective approach. The combo lowers down side effects of chemotherapy. This is a study on colon cancer, which were given FOLFOX. Selenium, an antioxidant, again, combines with proteins to form what we call selenoproteins, which is used by the thyroid and the immune system as well. These are depleted in mercury toxicity, commonly in fish eaters. That's why we already know that mercury is involved in the pathology of our patients. So we should always think about replacing selenium, and usually found in the concoction of MTE, which is the multi-trace elements. It's actually containing selenium, copper, chromium, and zinc. When you also give somebody glutathione and they have a reaction, this might be related to low selenium levels. For me, my experience with my patient who had low selenium when I gave them glutathione, it actually led to excessive vomiting. So they can present in so many different ways, but when I replaced the selenium and I gave glutathione again, so as I repleted those levels, they tolerated glutathione better. And again, less than 400 micrograms per day as recommended dosing. Here you would see on this figure how selenium is used by glutathione peroxidase to convert hydrogen peroxide to water. And here also oral selenium, be cautious in using it on prostate cancer patients, which can actually lead to aggravation. Potassium is actually 2 milliequivalent per mil recommended, is what I recommend. Again, no IM or IV push due to its corrosiveness to the veins. Reason why it is infused in the hospital, you would notice this with cardiac monitors and even in a multivitamin mineral therapy. I don't want you to think that you can actually do repletion for people who are deficient in potassium because it's only used in these multivitamin mineral therapy bags for mineral balancing. And most common way of administration is 2 to 5 milliequivalents in 250 or 500 mil given 1 to 3 hours. Emphasis is in the use when you're using high dose vitamin C, for example. This can actually lower down what we call the extracellular potassium. Reason why it's something that we need to add in the bag of high dose vitamin C. And this is the co-transport. As you would see here, sugar, also with a similar molecule of high dose vitamin C or vitamin C itself, stimulates the coupled transport protein, plus now influencing sodium influx, leading to increased intracellular sodium, stimulating the sodium potassium ATP pump, leading to increased sodium extracellular fluid, leading to, again, to increased potassium intracellularly, thus lowering the potassium on the extracellular side. That's why in that bag, you need to have your potassium when you actually infuse your high dose vitamin C. If you're planning to give your potassium IV push in your IV room, you're going to turn that IV room into a lethal injection chamber. So don't do that. For chromium, this is something that we commonly use in insulin resistance or in diabetes. And here's a case study that shows the decrease in insulin dosing needed for a diabetic when actually given chromium. You can see how it stimulates the receptors to let sugar in again, lowering down the demand or the dosing, the higher dosing required for insulin in diabetic cases. Zinc, usually in 5 milligrams per mil. Sulfate is better in IV form for better solubility. Not to be given more than 10 milligrams per mil in IV. Indications that I use it on for my patients would be hair loss, immune boosting, wound healing, impaired taste and smell, especially now post-COVID patients are coming through the door, and also fertility, especially for male, and of course the men who are actually using BHRT, especially testosterone specifically. So osmolarity, so these are considering all the components of a multivitamin mineral drip, and this is something we compute. And this determines if the infusion is painful or non-painful for the patient. So your pharmacy will give you these numbers if you ask them in terms of the components. And another term for this would be tonicity. It's also what we call the concentrate of solute in relation to the solution. So the formula here is the total amount of volume per milliosmoles over total amount of fluid volume times 100. And the answer usually ends up with a milliosmol per liter equivalent. So the normal levels where you want to be is around 600 to 1200, which will tell you that the infusion is going to be well tolerated and will be comfortable for your patient. You don't want this in your IV room. Somebody's in pain and in the distress signal or during their infusion. You want this in your IV room, a happy, comfortable, non-complaining patient who's actually going to be thanking you for the therapy that they received. So again, I want to thank everybody for their time, and I hope this lecture helps everyone in terms of their clinical approach towards IV therapy, and hopefully this elevates your practices altogether in opening your doors through IM, IV if you're not doing it, because we're all in here together, and we can help you out as you do this. Again, questions and comments and feedbacks, feel free to contact me anytime, and thank you again.
Good lecture.
Thank you.
Do you like lactated ringers over the IV saline?
It depends. So when you talk about lactated ringers, I use that a lot for more of a multi-purpose. For example, somebody who's gonna get a vitamin bag from me, but I know they're an athlete and they had just recent training and they have lost a lot of electrolytes. So I put that in there for them because I know it has sodium, potassium, calcium, and even all the other
Yeah.
minerals. But for, I mean, as a standard, somebody who's just normal saline will do. But also, there are some interactions that you need to know about lactated ringers. It can't be used for other solutions. For example, be cautious about sodium bicarbonate being mixed with lactated ringers. So there are some studies out there that they do form precipitates. And another one, when you use phosphatidylcholine, I wouldn't suggest you using lactated ringers because again, precipitates will form because of the chemical reaction. So when you want to use phosphatidylcholine or even plaque X, D5 is actually the best solution carrier for that.
That's great.
I have a question. When you do a vitamin mix, would you follow that with a glutathione and then an NAD in that sequence? And then if you, would recommend any NAD infusions, any suggestions on that? You didn't mention that one.
Right. So for the, let's go through the glutathione question first. I see a lot of practices actually mixing their glutathione in the same bag with their vitamin drips. I wouldn't suggest that. The reason for that is glutathione has been found to be a very unstable molecule. On studies, you can even ask Dr. Nayan Patel, who was an expert of formulating the liposomal glutathione, that the glutathione should be given by itself. So in my practice, I give the vitamin drip first, and then I actually put the glutathione afterward, may it be through a push, or even as you go higher in the dosing, I would suggest do that as an IV push. So for the NAD protocol, I have seen practices mix NAD with a vitamin drip as well. The thing with that is, again, are you risking the fact that NAD can actually react with these molecules? As in my experience, I don't, for the reason that I have tested it on patients. As I infuse NAD with multivitamins along with it, they would have that reaction with NAD. The most common one will be palpitations. If you go fast on that IV drip, you would see them palpitate, and they would even tell you probably slow down that drip, and they wouldn't want to go that fast. So that's how I know that NAD is a little bit more stable than glutathione, and it's actually still working even with the mixture of the multivitamin drip. But I have also seen, and I've tried it also to separate that. It's just a longer infusion. As we all know, NAD drips can last for at least 2 to 3 hours, even 4, depending on the dosing that you're using.
Wow. That would be
Well, my question was the sequence, was not mixing. I never mixed them. But the
Okay.
sequence, you would do your multivitamin, then
First.
you would, including the vitamin C, then you would, and minerals, and then you would do your glutathione, and then your
After.
NAD. And that's for the pathway, like the sequence in pathway, correct?
Yes, that is correct.
Yeah. Okay, thank you.
What do you think about Olympia? They have this vitamin C, glutathione, and zinc, or vitamin C combo with glutathione. What do you think of that?
Yeah, I've seen that, and I'm pretty curious about that, just because I asked. So we work with local pharmacies here in Nevada, and I mentioned that product to them. So they're just saying, of course, if you want to look into it, ask for, I guess, studies that they have and stability studies, meaning in terms of how stable that glutathione is. Because out of every pharmacy that I've asked about, because of course everybody just wants to go in and out of the office when you get an IV drip. So I really am looking forward to having that same concoction that you mentioned, so just to make it a one-stop shop. But they're just saying yeah, you're probably wasting their money. But again, I cannot vouch for Olympia. I have seen that product before, and I know Olympia is a very credible pharmacy.
Yeah.
I don't know if Mike does IV medications, that maybe he can chime in into that.
Any suggestions for ALA? Usually for neuropathy, they recommend ALA, and then, again, with the Bs probably, but ALA maybe should be in D5. Any kind of comments on that?
Yeah, so I do ALA as well. And what I do with that is if you want to mix it with uh, vitamins, I usually start with the ALA first. And then after that, you follow the bag with the multivitamin bag. The doses that I have done with patients, actually, you usually want to do this ALA dosing in an incremental phase, like a 200 milligrams per mil. And then you can go to 400, 600 milligrams. So the dosing of suggest, I mean, I have seen practitioners do it in 1,000 milligrams, but I already found my results with sticking with around 2 to 400 milligrams. And mostly I use this with post-chemotherapy patients that actually has left over from neuropathies from the platinum drugs. So, but again, start this in, it gets expensive as well when you, it depends on the pricing that you charge your patients, but it should be in a gradual phase when you introduce the dosing.
It's great also for cyprotoxicities, for patients that had cyprotoxicities.
Right. And even it's being used for hepatitis. So that's there's also a patient that I have that uses that, and even post neuropathies, for example,
Yeah.
like shingles. So there's that's a, I guess I mentioned during our presentation, it's one of the more challenging conditions that you're going to be treating out there. And ALA IV is a very potent route and medication to use with, along with your other modalities.
How much have you used the IV NAD, and how many milligrams do you do in a setting?
So that also is in increments. The the highest that I've gone, I think, is what, 500, 600, just because of the time. The higher the dose that you put in there, I've seen again, yeah, 800, 1,000 milligrams, and these are cases of addiction. But my clinic is not in an addiction clinic, so I don't go that far. But it's really just more of the time in terms of how long you can let a patient sit down, and also for staff to be staying there to watch out for these patients. But very safe infusion if you know what you're doing. And also, yeah, you just want to get your NAD from reliable and reputable companies.
Yeah. I've had a lot of requests from this ever since that Huberman podcast that released a couple weeks ago. He brought this doctor on who said that, NAD infusions was the most powerful thing he's ever seen in functional medicine for regenerating all sorts of conditions, neuropathy, brain trauma, yeah, you name it. So it got people kind of excited to try it out.
Well, I don't know if you remember Dr. Jin. So he was saying that IV NAD does not go intracellularly. It's actually more of extracellular. So again, so many theories about NAD, but as I say, it's always about the results of your patients. When you give it to your patient, and if you see the results, may it be subjectively through their symptoms or objectively through their labs, that I think that's what counts. There's just so many outliers out there about NAD. But again, I'm a big fan.
Good.
Kamal, do you have a question, or is that your hand raised?
Yeah, hey, awesome lecture. Really, really enjoyed it. Thank you. Thank you so much. I just wanted to give you my perspective. I'm a doctor on a good day, but I'm also a cancer patient. So
On a good day.
yeah,
I'm sorry to hear that.
yeah, no, I'm in remission now, but doing these IV drips, I think um, helped me with sort of my cancer journey as well. So I would get on I had metastatic myeloma. I mean, my bones were Swiss cheese. I had tumors everywhere. It was terrible. I had 7 pathologic fractures. but so on a weekly basis, I would give myself high dose vitamin C, like 25 grams. I'd give myself ALA, um, ozone, and glutathione as well. And I would there was plus and minus a few other things, but those are the main components that I would get essentially on a weekly basis. And within about a year of diagnosis, year and a half, I was in remission. And I think largely because there's lots of studies that show that vitamin C and ozone as well, it actually makes chemo work better. Not it helps certainly help me recover faster, but I think there's a lot more studies showing that these IV drips, depending on the components, may actually help chemotherapeutics work better.
Right. So yeah, we actually do IPT. So in our facility, that's in the cancer center. we always get the question from oncologists here, local oncologists here, that IPT actually is being negated when we actually do antioxidant therapy. So
Right.
how we do our IPT is we give it on a Tuesday and a Thursday, and then we give our immune therapies, which was you just mentioned, high dose vitamin C, ozone, peroxide, in between days, MWF. So they're saying that what's the use of the chemotherapy drug that you just gave when you're actually giving antioxidants, when the purpose of these chemo drugs is to be oxidative, right? But
Right.
as we tell these patients that, hey, if you look at, so we are conducting a study in our cancer center, and the study that really highlights the therapy's effect would be 10 years remission for a percent of at least 56% versus chemotherapy of the conventional side. These are studies from US and Australia, which actually only reached 5 years. And the percent that reached 5 years for conventional chemotherapy would be around 5 to 8%. So
Yeah.
that's why when we get a question like that, like how can you even explain the data that we have in relation to those things are counterproductive to such conditions. So I agree with you, definitely. I've seen that happen.
And another thing, just to add on to what you were saying before, the alpha lipoic acid, actually, it's a wonderful way to help pull out some heavy metals, heavy metal toxicities in the body as well.
Oh yeah, I've done that. I use EDTA most of the time, or even DNPS,
Yeah.
but that's a nice thought to add to the protocol.
Yeah. Do you do calcium EDTA then?
We do, but I use more of sodium EDTA. Calcium is something that we do as a push, though it's a faster way. It's more focused really on metals, but in relation to our approach to EDTA, we focus also in terms of the cardiovascular aspect. And sodium EDTA, according to the TAC trials, actually has been backed up more in relation to that. But either way, I do see if you're talking about heavy metals, calcium and sodium actually does their own lowering down of metals.
If it's not too much trouble, could you talk a little bit about how you do your sodium EDTA drips?
Oh yeah, yeah. So how we do it in terms of how we mix it or infuse it.
Infuse it.
Oh, so our solution carriers would be usually sodium chloride. Oh, I have seen sodium EDTA mixed with lactated ringers, but there is a theory behind that there's calcium in lactated ringers. So just be cautious about that one because it can bind the medicine already,
Right.
and of course lowering down the dose that you want your patient to receive. But so sodium chloride is our main carrier of choice. And of course, for 250 milligrams per mil of sodium EDTA, we give at least 5 to 10 mils for that. So this again is another IV that you want to do gradually for your patients. And also, not everybody's going to be a candidate for this. So checking your GFR, creatinine, or even cystatin C would be one of your prerequisites for somebody who can actually receive chelation therapy. And this is going to be in a 500 ml bag, and depends. Sometimes we give it in higher amounts of carriers depending on how a patient can get dehydrated with that. But usually the standard is 500. 250 can be also, but for lower doses. And these are the patients who just wants to go through it faster. But I wouldn't suggest that again because it's the high stress that it induces on the kidneys. And yes, so two specific EDTA indications for me in general would be heavy metal toxicities and also cardiovascular conditions. And people were saying, I have done EDTA on patients with chronic renal failure, but not in stages 4 and 3, 1 and 2 probably, and I have seen them improve. So you have to remember maybe that renal artery is just calcified, and that's the reason why this GFR is not showing up normally in your panel. So when you blast them with low dose EDTA for maybe what, 10, 15 sessions, you would see some of these GFR bump up. But I definitely want to make sure that you have the awareness of monitoring the GFRs as you move along with this.
But you have to have a cardiac monitor, right, for this sodium EDTA, and you put it
Not
in.
really. We're not that complicated.
No.
It's really more of a experience. I was fortunate enough that I worked with a clinician here, Dr. Ibarra, who had been doing chelation for like 30 years and has just taught me how to do this safely without cardiac monitors. So, but I have heard of that, but for me on my end, I don't. Maybe I should.
Thank you.
You're welcome. All right, more questions? Or
There was
everybody's
one question in the chat that I texted to you from
oh,
Dr. Anna Fishbein, and her question was how to diagnose Wernicke-Korsakoff syndrome, what therapy, and then thank you.
okay. So Wernicke-Korsakoff syndrome is actually it's the alcohol acetaldehyde depleting B1. So this is severe B1 deficiency when you actually consume a lot of alcohol. That's why when I mentioned it's not going to happen when you just have a beer with your friends watching football. This is something that happens when you have excessive intake, and usually for chronic alcoholics. So this depletes the brain of B1, that thus manifesting with gait problems, again, mental instabilities. That's why they show up in the ER most of the time as psychotic patients. And the magic here is I have seen this in the ER before when I was still in the hospital, that we just give an infusion of B1 to these patients and they just suddenly flip around. That's why just having and considering the fact that any pathological condition out there, we should always, as part of our differential diagnoses, we should think about mineral and vitamin deficiencies. So as we all know, as I mentioned to you, the food quality is not the same anymore. Everything, even prescription medicines, depletes all of these nutrients and vitamins that we have. But again, going back to your question, yes, that's how it's a very complicated phase or one of the complications of severe alcoholism that can be treated simply via B1 infusions or even injections sometimes.
On the same topic, and it's the holidays, what is maybe suggested IV that you would do for hangover?
Hangover. Okay, so that's one of the things that we see here because we have, I don't know if you heard of Burning Man. That's pretty close to where we are. And after this event, we see a lot of them because they stay here in Reno as a part of the after party of Burning Man. So as a concoction for that would be, so we give the regular Myers cocktail, or we modify the Myers cocktail by giving them at least a liter of fluid because the majority of these people are very dehydrated. And as part of that, we like homeopathic remedies. So as part of our anti-nausea remedy, this can be given as an injectable, is Nux vomica. Nux vomica is something for
Yeah.
vomiting, nausea, homeopathy, yeah. And but yeah, so that's one of them as part of the concoction. But you can also lose your regular Zofran and your anti-inflammatory. You could Toralac, you can use
Yeah.
that as well as part of your IV drip. But I think if you, in my experience with these hangover patients, just give them ample hydration and good amount of vitamins. Majority of these symptoms will stabilize. It's just that you're treating them symptomatically with your Zofran and your ketorolac. But the key here to really get them out through the door and feeling okay would be your hydration bag and also your good amount of nutrients and vitamins.
But you don't mix the ketorolac with your vitamins.
No, no, no. You have to do
Yeah,
that in a
separate bag.
bag. Mhm.
Yeah,
That's
separate bag
right.
that and Zofran. Yeah.
Yeah. And even Zofran.
Yeah.
Zofran,
Yeah.
yeah, is
I usually
separate.
hydrate, like start hydrating with Zofran and then
Oh yeah, you can do
do
that.
the vitamins and then the ketorolac for the headache.
Well, here's a trick. I guess maybe not even a trick. Maybe you guys know about this already. The most important component of an IV therapy bag is the amount of solution that you give to the patient. It's even
Yeah.
more important than the vitamins and the components at
Mhm.
the time, because a majority of the symptoms that people feel
Hydration.
are because of dehydration.
Yeah.
Yeah.
So you won't go wrong with
Mhm.
a good amount of carrier fluid.
Yeah.
Yeah. I always do a liter.
Yep, there you
Yeah.
go. It's just, yes, the time. And also, the challenge with us here in the practice are veins. You really have to have good people working on veins, or you yourself are very experienced, because there are people who just does not have any veins, and even your needles, it will cost you a lot just for trying and trying over and over again. But the skill of putting that needle inside a vein is, again, one of the most important skills to deliver that fluid into the system.
Yeah. Very good.
That was a fun topic. Thank you so much.
Oh, thank you. Yes. If you have questions, feel free to email me, or if you have, yeah, anything that you, I guess, want to request for lectures, just tell Shell or us. We'll definitely do it for you guys.
No, it's
Now,
great because you mentioned like the dosage. Like I use Olympia, and then every time when I talk to the pharmacist, like, oh, 1 to 3 mLs per, per bag. They
Right.
just like, and then you have to go back and look, somewhere for the exact dosage. But you
Mhm.
have really great tips there. Thank you.
Yeah, it's for me, it's really about sharing. This is something, if I see something successful, I don't hesitate to share it to my colleagues. So you guys can also spread the word on how good integrative medicine would be. So it's a win-win for all of us.
Yes.
you said something that it was stated rapidly. I don't know if I heard it correctly, but you said that progesterone can be a precipitating factor in migraines,
No,
or did I hear it wrong?
right. It's mostly progesterone deficiency, because I see a lot of BHRT patients also, and when they come in with migraines, the first thing that you always think about is replacing, especially for more for the women, that you think of low progesterone, especially if they're perimenopausal or menopausal, and at the same time magnesium. So those are the two keys for more of the hormonally imbalanced migraines that you will encounter. And of course, yes, as estrogen gets depleted as well, these migraines gets more aggravated. But really, as I found out, that it's not really there. I don't know if you heard of Dr. Jack Monaco from A4M. He taught me that the majority of perimenopausal symptoms, including migraines, is not related to the lowest number of progesterone that is being experienced by the body. It's really the ratio of estrogen progesterone. As
Yeah.
you get them closer together, these symptoms abate. But as you put more estrogen and less progesterone on this patient, as the levels go farther apart, these perimenopausal and menopausal symptoms gets worse. So that's why you start with progesterone, because that's the first one that gets lower in the perimenopausal period.
But that's why also they get migraines at the younger age when you're asking history, and it's around the period time. It's a clue that it's progesterone imbalance. So it doesn't have to happen perimenopausal. It's very common even for younger females, and that's one thing you get from history.
That's right. Yeah, and then also, yeah, there's so many approaches that I've seen in practice about treating migraines and Yeah, and symptom PMS symptoms that I see transdermal being used most for the women, but for the reproductive age women. But I see also a lot of responders with PO progesterone. Again, this is probably old thinking. I don't know. I'm sure. Maybe correct me, because I hear that a lot from older faculty in A4M, that they only want to use transdermal progesterone in these reproductive women and save PO for the older age group. But for me, as I see them, they respond better with PO. So again, everybody's different. It's just, again, your clinical experience will dictate that for you.
Well, it's hard to, I mean, the pharmacist is on with us, but it's hard to absorb the transdermal progesterone. It's really difficult. It's better absorbed from mucous membranes, not on the skin. But also an important point is to cycle them, because you don't want to give them a low dose so that you're not stopping their periods.
That's right. And if you're talking about absorption in terms of topical, there is I don't know if everybody knows about this. I'm sure Carol does. Versabase. Versabase is a bit
Yeah.
more expensive, adding it to your hormone concoction,
Mm.
but ensures higher absorption in relation to what you want to deliver into that system.
Yeah.
It's true. It's hard. It's very variable with the type of cream used. Once David Zava told me, depending on the type of cream being used for progesterone, your absorption can be as little as 20% or as high as 80%.
That's right.
So
And
it
I'm sure
makes
you
a
heard
big
of
difference.
Carol, Mucolax. So I have patients who uses intravaginal creams down there, and it
Mhm.
pours out. And Mucolax actually makes this intravaginal hormone adhere more to the mucous membranes inside.
Right. One of my old professors from pharmacy school invented Replens, which is a vaginal lubricant that was designed to stick to the walls of the vagina longer. And then he added progesterone to it, and it became the drug Crinone. That's how it's designed for longer adhesion to the walls of the vagina.
Oh, interesting.
Yeah. I think progesterone works however you use it.
I
It
know you're the
works.
proponent of progesterone.
Yeah, it really does work. I mean, we're having all kinds of issues. You know, the endocrine society, menopause society is saying, oh, you can only have oral to protect the endometrium. When you try to measure topical progesterone in the serum, it doesn't always show up. So those groups want to have the position that if you can achieve luteal levels of progesterone, ipso facto, you've protected the uterus. But that's not necessarily true either. You're going to have to check the patient to be 100% sure. You can't say a luteal level sometime after an oral ingestion. You're not staying at luteal levels the whole time. It's rising and falling. So it's just craziness going on.
What are your thoughts on putting transrenal progesterone on, let's say, fibrocystic breasts? There's some mixed thoughts on that, that's not
Yeah.
advisable. In the future, cancer might form, and you might get blamed for that transdermal
No.
progesterone being placed there.
No,
What are
it's
your thoughts on that?
perfectly safe and actually very helpful. I actually, that was my introduction to progesterone. That was my issue. When I was in my early 40s, I had fibrocystic breast disease for all my life up until then. And I started using progesterone on my face only for vanity reasons, because I was reading at the time, those little wrinkles at the corner of your eyes were a sign of low progesterone already. So I was putting some on my face, and I used Proganol, and that one had 30 milligrams per gram of cream. So in about 4 months, I noticed that all my fibrocystic breast disease was gone, except for the biggest lump I had, and that was smaller. And Eugene Shippen advised me to add some iodine.
Mhm. Yeah.
And that worked like a charm. I did have one colleague who tried that and it wasn't quite good until she added DIM and then gone. But definitely, and if you have sore, tender breasts, like in the luteal phase for PMS, putting progesterone cream right on your breasts will reverse that very quickly.
Yes. Yes, that and iodine.
Yep.
You can do topical Lugol's 2% solution. You know, I was just at a surgeon's dinner. They bought me a steak dinner, and it was on breast disease. And the surgeon, I got up and I asked her if she knew anything about Lugol's, iodine, and progesterone topically for fibrocystic breast disease. And you know what she said? She
What?
politically corrected me. She said, "We don't call it fibrocystic breast disease anymore. This is not what we term." I said, "What do we call it?" She said, "It's just normal breast tissue."
Yeah.
They've normalized this problem.
Oh my God.
Yeah.
There's do you guys remember Dr. Mark Starr and his book on thyroid?
No.
No.
Well, never mind. But so his mom was in her 90s and she was diagnosed with breast cancer. I got a chance to talk to her. She said, well, she didn't want any stuff being done to her breasts. So Mark did treat her with high dose IV vitamin C. And then he put Lugol solution on her breast. I would say dilute it because it's kind of caustic to your skin, but you can dilute it a bit. And he said, Carol, was so interesting. He said it's like her breast, the veins would just light up, go into the tumor with that iodine.
Hmm.
He said, I wish I had a picture to show you. Interesting, just sucking right up. There was a doctor in British Columbia, David Derry, was treating breast cancer with thyroid and iodine. The name of the book is Iodine and Breast Cancer. He was successful.
Yep.
And they took away his license.
Oh wow.